Hello, thanks everybody for coming. You may notice there'll be some overlap here between my talk and Skip's talk. There's some overlap between all of us, what we do, but I'll try to keep it a little bit more focused on the meniscal tears and the sports injuries that can lead to arthritis, and then talk more about the partial knee replacement, which Dr. Zabilski touched upon briefly. So, again, exit 10, 95 Tremont Street. This is our office. I just want to give one additional plug. The second floor here is our physical therapy unit, which I'm the director of at the moment. And as we expand, we have an opening for full-time physical therapists. So out there, if any of you know any colleagues or fresh out of school candidates, send them our way. I believe there's a flyer at the front desk if you're interested in the contact information. So 25 years, Dr. Zabilski covered this. We have most of the capabilities right on site, and we specialize in pretty much all aspects of orthopedics, especially now with our two new additions in hand and spine. Affiliated with Beth Israel, so formerly known as the Jordan. So my background, I'm board certified in both general orthopedics as well as sports orthopedics. I did my sports fellowship out in San Francisco, University of California, and my residency was at Harvard University, where I also did my undergrad, and medical school was at SUNY Stony Brook, where I'm going this weekend for my 15th year reunion. So meniscal tears. So I specialize in sports, which is primarily arthroscopy of the knee, hip, shoulder. I do rotator cuff tears, instability of the shoulder, mostly knee ACL, cartilage work, and then I do knee replacements as well. Both partial and total. I draw the line at hip replacements and shoulder replacements, as we do tend to specialize these days, and I have partners that cover that. So meniscal tears are very common. One of the most common procedures we do in orthopedics is the knee scope, which is usually due to a simple meniscal tear. So quick anatomy of the knee, menisci, there's two of them, a medial and a lateral. The medial is involved far more often than the lateral in terms of injuries, and there are little discs of cartilage that sit between the femur and the tibia that act like shock absorbers. So twisting type injuries, that kind of thing, can cause that tissue to catch or get caught between the bones and can cause it to tear. And they can be associated with ligament injuries as well. ACL, PCL, the collaterals are sometimes involved as well. So twisting injuries can lead to then swelling. Patients present to my office with a twisting type injury and say, my knee swelled up like a balloon, and then I felt this clicking, catching sensation. Those are the mechanical symptoms. Those are the ones that we worry about may be unstable and often will lead to surgery. Majority of them, though, tend to be stable, and we pick them up through physical exam primarily. Usually you have a pretty good idea of what you're dealing with just based on a 5-10 minute exam in the office. They'll have joint line tenderness. And then there are a variety of tests with fancy names, which really just involve stressing the meniscus. So by putting a load across the knee joint in a variety of positions and twisting the tibia, you can sometimes recreate that sensation. And this is something that even our therapists do upstairs and often pick up on these types of injuries and then let us know. So they come in a variety of sizes and shapes. The traumatic ones are the top row here. They tend to be clean tears, often in younger athletes, high school, college age, where it's a sudden twisting type injury which causes the otherwise healthy tissue to tear. They come in a variety of patterns. You have the bucket handle meniscal tear, which is displaced and can often present as a locked knee. Somebody can't extend or flex their knee because it acts like a little block to the motion. You can get these flap tears, which can flip in and out of the joint like a pebble in your shoe. They're not painful when they're off to the side, but as soon as they flip into the joint, it's painful. And then the radial tears here, which disrupt the radial fibers of the meniscus, leading to problems. And then the lower section are the degenerative type tears, which are more associated with arthritis. So if you have an already damaged knee from cartilage wear, so I use the analogy, it's like driving your car on a bumpy road. The tires are going to wear out a little quicker, and that will lead to more fraying and degenerative type wear of the meniscus, which we treat a little bit differently. So this is what the tear, a clean traumatic type tear would look like. This is a bucket handle through an arthroscope looking directly at it. And this is what a flap tear would look like. Again, inside the knee, you note otherwise healthy, clean cartilage above and below. And then this is what a degenerative type tear looks like. And you can see there's a little bit of arthritis here as well that leads to fraying and more tissue degeneration as opposed to something that could be repaired, for example. So the way we treat tears can involve debridement. The majority of them are these degenerative type tears that we simply trim back, restore a stable rim with a combination of mechanical biters and shavers to get the meniscus to restore its normal shock absorbing properties. This little piece of torn tissue isn't really doing anything other than causing pain. And then there are repairs, which we've been steadily developing over time. Used to involve big incisions, open procedures, passing sutures from outside the knee in and tying fancy knots. Now the majority of my repairs by far are done all inside, meaning entirely arthroscopically with these variety of different types of anchors that can be used to pass through the damaged tissue with stitches already attached and little slip knots that we can tie down, and results have been as good, if not better, than the open procedures. So quicker recovery time, less postoperative morbidity, discomfort, less pain, so forth. So this is what a meniscus repair looks like inside the knee joint. You can see little anchors here. This is actually one of the previous generation type repairs. Now we're using more stitches and smaller anchors. So the diagnosis of meniscal tear, as I said, is generally a physical exam type finding. X-rays, weight-bearing views can tell you if there's some arthritis, but more often than not, we'll confirm the diagnosis with an MRI. So this is a normal MRI. Little dark triangle of the meniscus in cross-section is what it normally looks like. And then if you have a tear, you can see a little line running through the posterior horn here, and probably a little displaced fragment because the triangular appearance is lost. So MRIs are great, but their specificity and sensitivity is not 100%. So oftentimes you're looking at shadows saying, oh, is it a tear or is it not a tear? And if it is it unstable or not? So you can see big tears, but subtle defects are not always visible. And then the biggest issue is after you've repaired a meniscus, somebody starts developing symptoms again. You have to wonder if the tear if it's retorn or if the repair has failed. Particularly difficult to assess on an MRI. Scar tissue and healed meniscus can look very similar to a torn meniscus. So we're often resorting to MRI arthrograms, which are more invasive. You have to inject a dye. There are allergy considerations and so forth. So oftentimes you end up doing what's called a diagnostic arthroscopy, taking a patient back to the operating room just to look, which involves even more potential risks from anesthesia and the risk of infection and so forth. So we like our toys, and this is one of the latest that I've adopted in the office over the past couple of months. It's called the Vision Scope. And all it is almost the size of an 18-gauge needle with a fiber optic camera in it. So office-based, we do this right in the exam room, make a small numb area with lidocaine, and we can insert a needle that's basically the size of an 18-gauge and look right there in the office. No anesthesia, no other than sterile gloves, no major setup. So I'm starting to do these sort of Friday afternoons once a month and line up patients who otherwise would not have an indication for an MRI, or the MRI is going to be equivocal or non-conclusive, even the MRI arthrograms. So it's used to look at the articular surface as well, so we can see arthritis and where it's located, help to determine if someone's a candidate for a partial versus a total knee replacement. Look at meniscal tears, and they can be done in the shoulder as well. And instead of taking someone back to the operating room for a second look, you can do it simply right there, for a quick 5-10 minute procedure. And there are other reasons why people may or may not opt for an MRI, including absolute contraindications like pacemakers and other loose implants, being too big for the MRI machine, or being afraid of it. So here's an example of what it looks like in the office. This is actually a case. This video may or may not work. So looks like it's not going to work. But just kind of shows what the picture on the right is, what it looks like through the needle. It looks just like it does through an arthroscopic camera in the OR. And this example is a workers' comp patient who had a repaired slap tear that continued to be symptomatic, so the vision scope determined that the repair had healed with no new pathologies, so eliminated the need to go back to the OR, and patient was able to return to work right away. So basically taking the place of second look arthroscopy and can help to determine the rehab or where you are in healing and when you can return to sports, that sort of thing. And specifically helps out where MRI has lacked, which is in defining whether meniscus has healed, or meniscal repairs have healed. And also, at the same time, in the office, you can do an injection, hyaluronic acid or cortisone. If you find that the symptoms seem to be more due to some mild or moderate arthritis, you can do an injection right through the needle that you're using the camera through. So moving on to osteoarthritis, a little bit of overlap again with Dr. Zabilski. So it's a degenerative bone disease where the cartilage wears out, which removes the buffer between bones, removes that smooth interface that allows the joint to slide friction-free. It's a huge problem, health problem. 15 million Americans suffer arthritis of the knee alone, and almost 50% of people will develop some form of arthritis in their knee over their lifetime. 55 plus is the peak knee pain candidate, and this is going to grow as the population ages, doubling by 2020. So it's going to become a bigger issue, and the signs and symptoms begin with pain, standing or walking short distances, climbing up and down stairs, getting in and out of chairs. The stiffness, getting up, especially first thing in the morning when you're getting up out of bed, we call it startup pain. Swelling can be associated with it, grating sensations or the crunching sensation of the rough bone surfaces moving against each other, and decreased range of motion, and sometimes instability, and ultimately leading to reduced activity. Start not being able to do the things that you want to do. So the progression begins with early stage mild arthritis, often related to old sports injuries or involves minor defects, loss of cartilage. So you can see a little bit of wear on the medial femoral condyle. These are the types of repairs or situations where there are cartilage repair options. We can get cartilage to regrow in small areas of the bone where it's otherwise healthy. And then as it progresses into the moderate stage, increased pain, the arthritis starts to spread a bit over, say, an entire compartment. We call the three compartments of the knee: the medial compartment, the lateral compartment, and the patellofemoral joint. So moderate disease tends to involve one or two of those. And then you get to the late stage, the severe disease, where you get more disability, severe pain. Walking up and down stairs is even challenging, and it ultimately becomes a total knee problem where every compartment is involved. So again, the anatomy, things that can lead to arthritis. We covered meniscal tears, ligament damage. Both of the two cruciates or the collaterals can lead to instability, and if the joint's not moving properly, then the cartilage will wear out quicker. And the kneecap tends to be involved as well for other causes, typically muscle imbalances in the quad and the hamstring, obesity, those sorts of things can all lead to problems with the kneecap. So this is what arthritis looks like on the x-ray. You have a normal x-ray on the left, which shows symmetric joint space all the way across, which is filled in with cartilage. The one on the right has narrowing of the medial compartment, showing that cartilage has worn out. And these are weight-bearing x-rays, very important to always get weight-bearing views. And they can be caused by alignment. So normal alignment, which actually don't see that often, is where the legs are perfectly straight. You can imagine if you drop a plumb line from the center of the hip down to the center of the ankle, it's going to pass right through the middle of the knee joint, causing equal wear on both medial and lateral sides. Bow-leggedness or the varus alignment will lead to accelerated wear of the medial compartment, the inner part of the knee. And then you have the opposite, the knock knees or the valgus alignment, which will lead to more progressive wear on the outer part because the joint reactive forces are moving more through the outside of the knee. So causes are also meniscal injuries, which we covered. Once you've torn the meniscus, you've lost a little bit of the shock absorber. Repairs seem to delay the onset of arthritis because you're sparing the shock absorber, but oftentimes you're removing bits of meniscus piece by piece, and each time you do, you create less of a shock absorbing situation and more of a point-on-point contact between the articular surfaces leading to cartilage wear. Obesity we touched on. The bigger you are, the more joint reactive forces they're going to be, the higher the load on the knee cartilage surfaces, the quicker it'll wear out. And then genetic reasons, a lot of things we don't know are probably contributing as well. So non-surgical options, I'd say the majority of the time there are these options that get most people back to their state of normal activity that they want to be in. Sports and everything can be allowed through weight loss, use of anti-inflammatory medications, usually standard ibuprofen, Motrin, naproxen, and then the injections, the cortisone, the supplements. We talked about the chicken shots. And sometimes simple changes in activity. You move from low impact running, kickboxing, step aerobics to more of the less impactful but just as beneficial activities, getting on a bike, swimming, elliptical, those sorts of things seem to preserve the joint. So lots of studies have looked at running. It doesn't cause arthritis. They've looked at ultra-marathon runners, people who run hundreds of miles in races through deserts and things. No greater risk for developing arthritis in those folks, but once you have arthritis, it's probably likely that you're going to accelerate the wear if you continue to run on cement with tennis shoes. So the treatments, moving on to surgical options, there's the arthroscopic procedures, which historically has been to go in and smooth down rough cartilage surfaces, the so-called chondroplasty or debridement. Variable benefits, been studies that have shown that it doesn't really help in the progression of arthritis, may in some cases even make it worse, so mostly diagnostic purposes. Things like the vision scope will probably take over this department. Arthritis associated with meniscal tears, different story. Mechanical symptoms, you can make a difference with the scope. And then again, the progression as things accelerate, this sort of thing you can still treat arthroscopically, but as you get into this stage or this stage, you're looking at more major operations. So the total knee replacement is considered the gold standard for severe arthritis of the knee. Lots of them performed great long-term survivorship, 90%, 15 years, and they can correct large deformities. Those bow-leggedness or knock-kneed situations where there's an alignment issue can be corrected very dramatically and effectively with these methods, with these techniques for the total knees. There are issues, though. It's a pretty invasive procedure, big incision, lots of rehab. It addresses late-stage arthritis very effectively, but if it's not late stage, if it's somewhere in that middle zone, you're inevitably removing healthy cartilage and healthy tissue, removing ligaments and things as well. The ACL is typically sacrificed, sometimes the PCL as well. For these reasons, a lot of our patients, even though they're candidates, will decline the hip or the knee replacement for as long as possible, basically till they're debilitated by discomfort and are not able to do the things that they want to do. And even the people who do go through it, there's a percentage of people who say they would not do it again. And the overall satisfaction rate is very, depending which studies you look at, isn't 100%, so room for improvement. So partial knee replacements have been around for decades, but they've never been widely adapted. And the reasons for this, so less than 50,000, a tenth or less compared to what total knees were done in the year 2007. The advantages are that you keep a lot more, you preserve a lot more of the healthy tissue. You leave the ACL and the PCL intact, which creates a more stable, normal feeling knee. and they've been traditionally performed with manual instruments, so basically using jigs and eyeballing things. And I saw plenty of these done in my residency, where guys who've been doing them for years, you just couldn't imagine how they could have good results, but you get a feel for it, but a pretty steep learning curve. And plus the human eye is only accurate to about 5 degrees or a millimeter or so, which can make a big difference in overall alignment. So narrow indications, you usually can only address one compartment. You almost inevitably just the medial compartment. Can't really address the patellofemoral joint if that's arthritic. And outcomes were widely variable because of the technical demands. End up with an x-ray that looks like this, where the component is clearly not lined up, and it's tough to balance the ligaments, and you end up with early failure because things like the tires in your car that aren't balanced, they're going to wear out much quicker. So back to the progression of arthritis, early stage sports injuries, meniscal tears, small cartilage defects. We can still treat arthroscopically with microfractures and cartilage implantation and all the other things that are great these days. But as you get into severe disease, total knee replacement is still an excellent option. But there's been this void here where patients have more severe disease that wouldn't be fixed with a simple arthroscopy, but it's not bad enough to warrant a total knee replacement. So we didn't have much to offer these patients until more recently that we got the Mako, the robot, so the robotic interactive operative device, which has made a breakthrough in terms of allowing us to do a lot more partial knee replacements, because we can now do them accurately to within a degree, to within a millimeter, and get the reproducible results. So they come in a variety of forms. You can do the traditional medial replacement. You can replace the patellofemoral joint if it's just isolated arthritis behind your kneecap. You can do the lateral one as well, less common, but done much more often now with the robotic technology than previously. Plus, you can do so-called bicompartmental replacements, where you can replace the 2 compartments, in this case medial and patellofemoral. And there are a handful of patients in the U.S. walking around with all 3 compartments replaced, but it's still off-label, not widely adopted, but maybe coming down the pipeline. So the biggest breakthrough in the robotic technology, the robot's cool, and doing the surgery is it's like video games, but the biggest breakthrough has been the preoperative planning. So what happens is every patient who signs up for a Mako gets a CT scan, a 3-dimensional CT scan of their knee 2 weeks before the procedure, which then goes through a process with software where it turns into an actual virtual model, and the implants are placed virtually long before the patient ever comes into the operating room. So you can actually move these in virtual time, watching how they line up and how things will track and how much the angles change. And so most of the work is done before we even get to the operating room. And then when you're in the operating room, this is what the screen looks like. So there's a version of the Wii as well. Here's the robotic arm, or the sensor. Here are the arrays in the patient's leg. And what we're doing here with a probe is registering the patient. So we're matching that knee to the preoperative CT scan. So this is actually the image of the patient's knee, right down to every little bump and osteophyte and contour. And once the robot is satisfied that it's the same knee that's in the program, and that everything's lined up, then it's just a matter of ligament balancing, which was another thing we couldn't do before the robot, which means removing the osteophytes, taking it through a range of motion, and seeing in different flexion how much varus or valgus you have, including external rotation. And if it looks like there's still too much of a knock-kneed or a bow-legged appearance, you can actually move the implants right on the computer virtually until you're happy with exactly where they are and satisfied with where the final placement is. And then it's just a matter of taking the burr, which is robot assisted, meaning that the surgeon still does the burring, but the robot keeps you within the coloring line, keeps you within the lines like in a coloring book. And with a burr, it's unlike a saw or the cheese grater. You're creating a perfect inlay for a round component that matches the contour of the condyle or the tibial plateau that you're replacing. And smaller incision, this is what it looks like after it's in. You're keeping your ACL and all the other healthy cartilage behind the kneecap and on the lateral side. And this is what the x-rays look like afterwards. So compared to that other partial knee replacement, you can see this is clearly lined up, both AP and lateral. And this is what every x-ray looks like. They all come out the same. It's very reproducible. And this is what a partial patellofemoral joint replacement looks like. And this is what a bicomp looks like. So this is the medial compartment and a patellofemoral compartment combined. So this patient had bicompartmental disease, but their lateral compartment was otherwise healthy. So that was able to be spared. So the biggest advantages are performed through smaller incisions than required for traditional total knee replacements. Only the arthritic portion of the joint is removed, preserving otherwise healthy bone and tissue. The implants are optimally positioned, so alignment is key to the survivorship of these things, which leads to improved outcomes, less implant wear and loosening. You spare bone so that if the arthritis progresses, you can revise to a total knee replacement without theoretically as much trauma as if you were starting from a previous total. So less scarring, reduced blood loss, which leads to less hospital stay. Most of these patients are staying one night and leaving the next day. Rapid recovery, as opposed to 6 to 12 weeks for a total. I'm seeing patients come in 3 weeks after this procedure, full range of motion, off assistive device, off pain medication, feeling pretty good. Not always, but we've seen it. So, and then the ligaments remain intact, which all patients describe as a more natural feeling knee. I've had a few patients who have a total on one side and a partial on the other, and they all prefer the partial. Outcomes, some of the studies have looked at how accurate it is. So that this study shows that it's in terms of millimeters and placement in a cadaver model or sawbones model, that using the robot, which is the blue column, is at least twice as accurate, in some cases more so, in terms of position and orientation of both the femur and the tibia. So getting it lined up is markedly different. And outcomes, all knee replacement or joint replacement procedures are ultimately measured in terms of how long they last. So compared to traditional partial knee replacements, the old style were at 2 years already starting to fail. 2%, 4%, average 4 to 5% were starting to fail at 2 years, which means that the curve is starting to rise and that a lot more of them will fail in subsequent years. Compared to the Mako, less than 0.5% at 2 years. And that we think is entirely because of alignment and getting things in correctly. And this was looked at as well relative to international registries, so large numbers of patients who had traditional partial knee replacements. Again, you're seeing this 4 to 6% failure rate at 2 years. Even compared to them, the Mako was much better. And there have been 4-year data that have supported this conclusion that the curve is staying flat. So we're expecting these partial knee replacements done with a Mako to potentially last much longer, maybe even be the only procedure you need. A lot of these partial knee replacements were always looked at as a bridging procedure. Expect them to last 8 to 10 years, and then you're going to move on to a total knee replacement. So done for young, which is why they weren't done that often. So my experience, I did about 50 cases in 2013. 40 were medial compartment, 3 were lateral, so far more common in the medial. I did 1 isolated patellofemoral joint and then 8 combinations of patellofemoral medial. And I had all my patients fill out the standard survey, the WOMAC, which discusses stiffness, pain, overall satisfaction, an average of 25 weeks post-op. The average age of the patient was 68, ranging over almost 50 years. The youngest was 38, and the oldest was 85. So everybody's a potential candidate. I don't go by chronological age, it's more physiologic age to determine who's a candidate for what. And then the results of the WOMAC pain score, 20 being extreme pain, 0 to 2 to 4 being none to mild. Most of the plots are down low with minimal pain and an average of 3 to 4 months out from surgery. There's an outlier here who's my pleasantly demented patient who I think was not quite sure how to fill out the survey because she said she was extremely satisfied with it in the end, but I left her in there for scientific integrity. So stiffness, same thing. Some of these were a little bit earlier post-op, so that's where these patients came in with still a little bit of stiffness. But majority of them, especially by 3 months, were mild to none, near full range of motion. Difficulty with daily activities. Again, this is my pleasantly demented outlier, but the rest of them all were getting back to their what they want to do in terms of the course of a day, whether it be sports or yard work or whatnot. And then the big difference, the overall satisfaction rate. Almost 96% were satisfied or very satisfied, with only about 4% saying neutral or dissatisfied. So that's it for my talk, and I'll open it up to questions. Yes?
Weight limit where you will or won't do a replacement?
So the question is if there's a weight limit for partial or total? Yeah. So there is a sort of arbitrary number we use, which is 300 pounds. There are exceptions made, and a lot of it depends on, BMI. But the standard is if it's over 300 pounds. If you're over 300 pounds, there's some evidence to show that the implant will wear out quicker. So I usually have most of my patients go on some sort of dieting program or even consider bariatric surgery before going through a knee replacement if they're in that category. Anyone else? Yes.
For a while they were recommending microfracture for early arthritis of the knee, and also they were doing Genzyme, articular cartilage regeneration. Could you give us your thoughts about that?
Yeah. So there's been a big move towards trying to regenerate cartilage. The future of the industry is probably going to be stem cells or some variation of that to get cartilage to regrow in otherwise arthritic knees. Right now, the science is that if you have a small defect that's otherwise surrounded by healthy cartilage, those are indications for either a microfracture, which means scraping making a clean bed by removing some of the subchondral, down to the subchondral bone, and then poking holes with a little microfracture awl, which is basically a pick or a drill, which accesses the bone marrow cells inside the femur or the tibia that form a little blood clot that fill in the cartilage area that's the defect, kind of like a patch. And those bone marrow cells are like stem cells. They can differentiate into cartilage and fill in that defect. And it's scar cartilage. It's not quite as good quality as the original stuff, but it works as a patch temporarily. The ACI, the autologous cartilage implantation, means harvesting some of your cartilage from your knee a few weeks beforehand and sending it off to Genzyme, where they grow it in a petri dish to turn a few hundred cells into several million cells and put it in a suspension. And then the traditional way was to take a little piece of periosteum from the top of the tibia, sew it over the defect with little stitches, and then squirt the cartilage cells in underneath it and seal it off with fibrin glue. So good results. Both microfracture and ACI had 85 to 90% success rates. We moved away a little bit from ACI because it is so labor intensive and a lot of fiddle and You had other issues where the periosteum would start to overgrow and cause problems in a lot of second arthroscopies to go in and trim things down because of overgrowth. So using more and more scaffolds now, which are similar, but using basically cartilage cells grown from other sources, so you don't have to do the harvest, that then are put into matrices, different synthetic materials that you can trim to fit the size and shape of your defect, and just stick that in there like a piece of putty, and the results are showing to be as good, if not better, than ACI. Doesn't work for general arthritis, though, unfortunately. Once the joint is degenerative and you're dealing with global cartilage loss, unfortunately, these procedures don't work. So it has to be basically a traumatic defect where everything, the majority of the cartilage in the knee is healthy, and you're dealing with anywhere from a 1 to a 3 or 4 centimeter defect at the most these days. Yes?
What's the rehab like after this cartilage regeneration? Are there limitations to weight bearing for a certain period of time? Is it just
Yes. So the question is if there's limitations to, or what the rehab is after a cartilage reimplantation or microfracture. So uniformly, it's 6 weeks non-weight bearing because microfracture plus the little periosteal patch or your matrix or whatever it may be is very fragile. And it's almost always on a weight-bearing surface, so you need to let that cartilage grow and differentiate and form a more solid patch before you can put any weight on it. And then it takes about 3 months for that patch to mature. So the 6 weeks to 3 months, you're doing some range of motion, stretching, gentle strengthening stuff, but any type of rigorous recreational activity or strenuous labor is at least 3 months. Yes.
What determines whether a surgeon uses staples versus sutures, soft sutures, and dermabond?
So the question is what determines whether you use staples or dermabond or absorbing sutures? It's really surgeon preference and patient preference. I mean, I take that into consideration as well. If someone requests a specific type of closure, I'll usually accommodate that. There's some evidence to show that staples are less prone to become infected than sutures that pass through the skin that are especially nylon or braided type material that's not monofilament. So the standard for a lot of surgeries which would have devastating results if becoming infected are still staples are kind of the status quo for trauma, total joint replacements, that sort of thing.
Vision scope, did you say that you use it primarily as a second look, or the other two are just more primary?
Both. So one of the biggest indications is, so question is, when do you use vision scope? Is it primarily second look after you've done an index procedure and you're checking to see how your results look? That's kind of what it was initially billed as primarily, but its indications are expanding to include first looks for, one of the indications I think is to determine what the arthritic pattern is if someone's a candidate for a partial or total knee replacement. So, which is hard to see on an X-ray or an MRI. Is there a question over here? Yep. Yeah.
I was just wondering about the Mako procedures with precautions afterwards as far as kneeling or running. Are there any things that patients will not do?
So the question is there any restrictions after a partial knee replacement? So there's no real absolute contraindications, and a lot of these are done in young, otherwise healthy patients, so they're going to get back to a lot of activities that maybe we prefer that they don't get back into, but it's about the same as it would be for a total. I tell people if they're tennis players, you'll probably get back to doubles tennis, kind of, gentlemen or less rigorous competition. Skiing, you'll probably be sticking to the blues and as opposed to the black diamonds in the trees. And running is going to produce a bit more stress on the implant than would be considered routine or run-of-the-mill. So I discourage patients, but there are plenty of people out there who do run and get back to pretty rigorous stuff that would make you take your breath away if I knew all of it, I'm sure. So, anyone else? Great. Well, thank you very much.